So today we're going to talk about drug metabolism. So as you know that drug metabolism is one of the processes that is involved in pharmacokinetics, and I think most of you still remember that pharmacokinetics consists of 4 components: absorption, distribution, metabolism, and excretion. And the processes of metabolism and excretion are collectively known as the process of drug elimination. So why talk about biotransformation? Why talk about drug metabolism? So this process is to get rid of toxic foreign molecules. And also enables us to excrete undesirable substances produced within the body, and to terminate action of some drugs, and it also allows activation of prodrugs. So drug metabolism, so the body transforms ingested drugs to detoxify them and make them easier to excrete. So the process of drug metabolism is to change the drug that we have ingested and to make it non-toxic and also make them easier to excrete. Drugs may be metabolized to more toxic products or to substances that are powerful treatments. Where does it happen? So it occurs mainly in the liver. So the liver is the main drug metabolizing organ, and the other places are the lungs, the gastrointestinal tract, the kidneys, and also the skin. So metabolic transformations, metabolic changes are called phase 1 and phase 2 reactions. In phase 1 reactions, you see alteration of the drug structure to make a more easily excreted polar compound. So it's something that is hydrophilic. So you change the structure of the drug to make it more hydrophilic and less hydrophobic through reactions such as the oxidation-reduction, oxygenation, and hydrolysis. Phase 2 reactions conjugate the altered drug. Okay, you know that the drug has been altered through the phase 1 reaction such as oxidation-reduction, oxygenation, or hydrolysis, and then the drug may proceed to undergo phase 2 reaction. So it undergoes conjugation. So it conjugates the altered drug to facilitate excretion. So examples of conjugation includes methylation and also glucuronidation. So phase 1 reactions convert lipophilic molecules into more polar molecules. So lipophilic becomes more hydrophilic and less lipophobic, and becomes more lipophobic. Okay, so those that are not so water soluble becomes more water soluble by introducing or unmasking a polar functional group such as the hydroxyl group or the NH2 group. So the phase 1 metabolism may increase, reduce, or maintain the drug's pharmacologic activity. So one important liver enzyme catalyzing this reaction is the microsomal cytochrome P450 monooxygenase, which utilizes molecular oxygen and NADPH as cofactor. So the phase 1 reaction includes the oxidation, especially by the cytochrome P450 group of enzymes, also called the MFOs, and also reduction, deamination, and hydrolysis. So the phase 1 reactions mainly involve 4 main processes. So it's either usually oxidation, reduction, deamination, and hydrolysis. And oxidation mainly involves the cytochrome P450 group of enzymes, or we call the CYP450 group of enzymes. So this is a diagram showing representations of the drugs metabolized by various P450 enzymes. So we have the CYP2D6. So the largest groups of drugs are metabolized by the CYP3A4 or CYP3A5 group of drugs, followed by the CYP2D6, and then CYP1A or CYP1-2 or CYP2 enzyme. Okay, the substrates are the primary enzyme for metabolism. So these are the main substrates, the drugs that are acted upon by this CYP1A2, and then we have the drugs acted upon by CYP2B6, CYP2C8, CYP2C19, CYP2C9, CYP2D6, CYP3A4, CYP3A5, and CYP3A7. Okay, so there are so many of them, and these are the substrates, the drugs that are acted upon. So they are the subject of the actions of these enzymes. And then we have the inducers. So the inducers increases the ability of the enzyme to metabolize the substrates. So we have this list of CYP1A2 inducers. So this drug, for example, carbamazepine, will induce CYP1A2 and causes increase in the ability of the enzyme to metabolize the substrate. So these are the substrates that I've shown you before. And then we have the inducers. So we have inducers of CYP2B6, and then we have inducers of CYP2C9, like carbamazepine, St. John's wort, and then we have CYP3A4, etc. So there are so many of them. And then we have the inhibitors of the enzymes. So the inhibitors reduces or blocks the ability of the enzyme to metabolize the substrates. So for example, if you have acyclovir, so acyclovir will inhibit CYP1A2, and when you inhibit that, so you will have increase in the, for example, if the patient is on amitriptyline, so there will be a higher levels of, or maintain, so the levels of amitriptyline will be high for a longer period of time compared to if you don't have the inhibitors. Okay, if you don't have this, the inhibitors, without the inhibitors, these drugs will be metabolized by CYP1A2. So, but if you have the inhibitors, then the drugs will not be metabolized, or it will, the ability of the enzyme to metabolize is reduced. So you have the levels of drugs are higher for a longer period of time. So it takes a longer period of time before the drug levels go down. Okay. So metabolized drugs include propranolol, phenylbutazone, barbiturates, and warfarin. So these substrates can increase enzyme activity by the process of enzyme induction, causing increase in drug breakdown, thus diminishing its potency. Okay, so these can be potentially serious. Okay, let's go back. So when you have induction, for example, if a patient is on warfarin, is given barbiturates, this will increase the breakdown of warfarin, okay, because of the potentiation or the inducement of the. So when you give an inducer, so it will increase the breakdown of warfarin, and the clotting times will be shortened because of the reduce in the activity of warfarin. So what happens is next is that we will increase the dose of warfarin. So when you increase the dose of warfarin, so the patient will be on a higher dose of warfarin, and then say if the patient is then taken off the barbiturates, and then you suddenly stop the barbiturates, you don't give phenobarbital anymore, so the enzyme is no longer induced. So the enzyme is no longer induced, and the higher dose of warfarin may cause hemorrhage. Okay, so this is a potential problem with drug induction due to other drugs. Okay, this is part of drug interaction. Okay, that was about phase 1 reactions. Now we go on to talk about phase 2 reactions. So in phase 2 involves the coupling of the phase 1 transformed polar drug to conjugates. So we know that some of the drugs undergo phase 1 reaction, and then after undergoing phase 1 reaction, they might go to phase 2 reactions. Okay, so in phase 2, so the drug conjugates to glucuronic acid, example digoxin, and then we have drugs that conjugate with glutathione, and then glycine, and also acetyl-CoA. So conjugated metabolites are generally inactive and easily excreted, and most of these groups are relatively polar and make the product less lipid soluble than the original drug molecule. So conjugate formation involves high energy intermediates and specific transfer enzymes. Okay, such enzymes may be located in the microsomes or in the cytosol. And some of these transformations are potentially dangerous, like the conjugation of paracetamol, because paracetamol is usually 95% glucurinated and sulfated with nearly 5% coupled to glutathione. So if therapeutic doses are exceeded, the glutathione pathway becomes quickly used up, and hepatotoxic metabolites are formed. So this is a process. So we have the process of glucuronidation and sulfation, which are the part of the phase 2 reactions, and then once the pathway has been stuffed up or it's saturated, then it will undergo the N-hydroxylation and rearrangement, which will cause production of NAPQI, and this will cause toxic reactions with proteins and nucleic acids. So to treat this, we will usually give N-acetylcysteine within 8 to 16 hours of paracetamol overdose. Now we'll talk about the first pass effect. So it's also known as the first pass metabolism or pre-systemic metabolism. It's a phenomenon of drug metabolism whereby the concentration of a drug is greatly reduced before it reaches the systemic circulation. So what happens is that in first pass effect, you have to know that the concentration of the drug is reduced before it reaches the systemic circulation, which is the intended place that the drug needs to reach. So it is a fraction of lost drug during the process of absorption, which is generally related to the liver and gut wall. So when you talk about first pass effect, we usually refer to the process of the drug being taken off by the liver and also the intestinal wall. So after a drug is swallowed, it is absorbed by the digestive system, and it will enter the hepatic portal system, and it will be carried through the portal vein into the liver before it reaches the rest of the body. And the liver metabolizes many drugs, and sometimes this happens to an extent that only a little amount of active drug emerges from the liver to the rest of the circulatory system. And this first pass through the liver thus greatly reduces the bioavailability of the drug. So you will have less drug available for action because it has been acted upon by, it has been metabolized in the liver. So you have, this is what we call the first pass effect. So this is just showing making it clearer what I've mentioned just now, how the drug goes from the veins and then into the portal vein, into the liver, and gets acted upon by the liver. Example of drugs with high hepatic first pass effect are catecholamines, morphine, verapamil, isoniazid, and aspirin. So these are the drugs with high hepatic first pass effect. Factors affecting drug metabolism. So first is the age. So very young people, very old people have reduced metabolism of the drug. And due to this reason, you have to be mindful of toxicity effect. So you would like to reduce the dose given in the very young and very old because of their lower rates of metabolism of drugs. And then the sex of a person, whether someone is male or female, will also affect the rate of metabolism of drugs such as ethanol, propranolol, some benzodiazepines, estrogens, and also salicylates. Diet and environmental. So we have certain drugs which can cause increase or can reduce the metabolism of drugs. For example, charcoal, broiled food, and cruciferous vegetables. This will induce CYP1A. Okay, so it will have a higher rate of metabolism and therefore less amount of drugs available to act in the systemic circulation. And then grapefruit juice inhibits CYP3A enzyme, and then we have cigarette smokers who are also will have sometimes a higher rate of drug metabolism. The state of health, whether someone is healthy or unhealthy, someone is sick or not sick, this will also be affected or will affect the rate of metabolism. Okay, we're talking about drugs, factors affecting drug metabolism. And then the liver function, genetic makeup, and also the existence of other concomitant medications. If someone is taking other conmeds, other concomitant medications, then that might affect the rate of drug metabolism. So genetic makeup include variations in acetylation. Okay, variations in acetylations of drugs such as isoniazid caused by an autosomal resistant trait leading to reduced synthesis of the metabolizing enzyme. So there are people who are slow acetylators, okay, so which involve like about 50% of the blacks and also whites in the US. Okay, so the safety of a drug may be severely reduced in people who are poor metabolizers, because they will have a prolonged high levels of a certain drug because of the poor or slow process of metabolization of the drug, metabolism of the drug. Okay, other drugs, co-administration of certain agents may alter the disposition of many drugs. Okay, when we talk about disposition, we usually talk about the metabolism or an excretion of other drugs. So when you co-administer or you give at the same time other drugs, it might alter the metabolism and excretion of other drugs. Mechanisms include enzyme induction, so results from increased synthesis of CYP-dependent, cytochrome-dependent drug oxidizing enzymes in the liver, and many isozymes of the P450 family exist and induces selectively increased subgroups of isozymes. Several days are usually required to reach maximum induction, and similarly the same time needed to regress after withdrawal of the inducer. Okay, takes a good few days. The most common strong inducers of drug metabolism include carbamazepine, which is a drug given for epilepsy and also given in bipolar disorder to reduce the mania, and then phenobarbital, also given in epilepsy, in seizures, phenytoin, also given in seizures, and rifampicin, which is an anti-TB drug. And also we have enzyme inhibition. So we are talking about mechanisms of how giving another drug might alter the metabolism and excretion of other drugs. So enzyme inhibition, the most likely inhibitors of drug metabolism to be involved in serious drug interactions are amiodarone, cimetidine, grapefruit juice, ketoconazole, and the HIV protease inhibitor ritonavir. So these are the most likely inhibitor of drug metabolism. So these drugs, when you give it together with another drug, which are substrates of a certain enzyme, and you know that these drugs act on that enzyme and inhibit the drug metabolism, so it will cause increase in the effects of the other drug. So you are more likely to see the toxic effects or the unwanted effects of the other drugs when you give drugs like amiodarone, cimetidine, and grapefruit juice, or also ketoconazole and also ritonavir. Suicide inhibitors are drugs that are metabolized to products that irreversibly inhibit the metabolizing enzyme. Okay. So these agents include ethinyl estradiol, or ethindrone, spironolactone, allopurinol, and propylthiouracil. Okay, spironolactone is a drug given for hypertension, allopurinol is for gout, propylthiouracil is for thyroid conditions. So I think that's the end for this session. Okay, thank you.